Good evening and welcome to everyone who's here. I don't know, we've got some new members of the committee and I'm just wondering whether it might be just useful to do a little run along the people there. And I see we've also got some members of the public here. Yes? So it's probably helpful for them to know who the people over on that side are. As well as us, we'll do a quick just saying who we are after you've introduced yourselves.
I'll kick off, Chair. My name's Mike Bell. I'm Chairman of Croydon Health Services.
John Galston, Chief Exec, Croydon Health Services.
Agnello Fernandez, Assistant Clinical Chair, Croydon CCG.
Mike Sexton, Chief Finance Officer, Croydon CCG.
Steve Moran, Director Commissioning from Croydon CCG.
Hello, I'm Barbara Peacock. I'm the new Executive Director of People in Croydon.
I'm Margaret Mead. I'm a Ward Councillor for Heathfield Ward and I'm Vice Chair of this committee.
I'm Carol Bonner. I'm Councillor for Fieldway Ward and I'm Chair of this committee.
June Haynes, Member Services.
Councillor Sean Fitzsimons. I'm Chair of Scrutiny and Councillor for the Addiscombe Ward.
Councillor Cathy Bee, Councillor for South Norwood Ward and a member of this committee.
Councillor Andy Strannock, Member of Heathfield Ward.
Darren Morgan, Analyst at Healthwatch Croydon.
And Andrew Pelling, I'm a Councillor in Warden Ward.
Okay, thank you everyone. Just a few kind of housekeeping things. Council members, officers and members of the public are asked to leave the meeting should you wish to make or receive a telephone call. Obviously, we've got a pack of papers. If you could refer to the pack page number if you're referring to anything rather than the report page number so that we all know where we are. And in terms of webcasting, please note that this meeting is being filmed for live and subsequent broadcast via the Council's internet site. Generally, the public seating areas are not filmed. However, by entering the meeting room, you're consenting to being filmed and to the use of those images and sound recordings being used for the purposes described. The webcasting system uses the signal from the microphone system, so members are reminded to please use the microphones provided to ensure your contribution is recorded. Please also turn off the microphone when you finish speaking. If the fire alarm sounds, you're asked to leave the meeting by the nearest available exit. Thank you. So agenda item 1 is apologies for absence.
We have no apologies, Chair.
Thank you. Item 2 is the minutes of the last meeting held on the 19th of July. We're happy to accept those as an accurate record. Agreed? Thank you. Agenda item 3, disclosure of interest. The committee need only disclose any interests that do not appear on their annual register of interest. If required at any point during the meeting, forms can be obtained from June.
Chair, just for the sake of transparency, I'm still involved with some of the implementation groups for the outcome-based commissioning process for over 65 services.
Andrew?
Chair, I confirm that I have further updated my interests since the annual review, and that has been provided to Democratic Services and the Monitoring Officer.
Agenda item 4, urgent business. There is none. Exempt items? Okay, we need to agree the split on the agenda tonight. And what I was going to say right at the beginning was that as much of tonight's business as we possibly can, and I understand there are issues that at this point in time can't be in the public domain, but if we could deal with as much business as possible in public, and you know, if we start asking questions that you think are straying into Part B, then by all means let us know, and obviously, you know, a judgment will have to be made whether it is or it isn't. But you know, we're obviously keen to do as much of this meeting in public as is possible. but we do recognise the difficulties with some of the issues that are being discussed. And if I can just say for members of the public, where items are of a confidential nature that maybe not, maybe only in draft form and not in a position to be made publicly available, when we reach that point where we're discussing confidential items, we will have to ask you to leave. Okay, thank you. So we have agenda item 6, which is the CCG responses to the special financial measures. And I think you've sent us a presentation. Did you want to run? Oh, are we doing this presentation in part A? It didn't. Yeah.
I haven't seen the presentation for CHS, which is, for people watching, is the hospital side rather than CCG. But I just want to clarify this issue about the what is a Part B item, which is the ones that are held with the public not here and the webcast turned off. Looking through the papers that were sent through to us, there is a presentation here which I believe CCG may go through, which I can't see anything within that is a Part B item, and it should be in public, because indeed the second paper, B1, again, I think there's a very strong case for most of that. I mean, we've discussed issues of the options over reducing provision in the last meeting, we discussed a number of areas that were on in that part of the paper, and then just reading through it, I really couldn't see how, to be honest, any part of that was a Part B item. I accept that the PwC report is private and confidential, and that's the part that is where we would have to be more careful and probably will need to be in Part B. Then looking through, as I said, the amended papers, and I don't know whether, if you're viewing from home, whether the amended papers are online at the moment, are they? Okay. So what I would also suggest is that we would do the Part A items for both Croydon Health Services and for the CCG as presentation before we go into detailed questioning. So that would allow the public to get a proper run-through of what's happening, because they won't have the paperwork in front of them because it's been given to us not early enough to put up onto the web. And then we can then make decisions where the Part B item cuts in, and we then don't have to ask people to stand outside for 20 minutes or an hour and ask them to come back in again. I just think in terms of, if you're reviewing on the web as well, you sort of know that there's a point where it's going to end, and it's not just going to start again. So I just wondered whether whether you as chair, and whether the CCG and CHS are more than willing to have, if they can, their presentations in Part A.
Or some of it.
The nature of financial special measures from the Trust side is that we are commissioned by NHS Improvement, our regulator, to develop a plan. The plan is still at a draft stage, and we're not permitted to share that within the public context. That doesn't mean that we can't share a substantial amount of information with the public in terms of the context for financial special measures and the approach we're taking to address that. On that basis, we would very much welcome the opportunity to place as much information as possible in terms of the emerging issues within the plan and some of the mitigations the Trust is going to need to make in terms of closing the financial gap. We're not at this stage permitted to share that in public, as it remains a draft which hasn't been signed off by our regulator. We would also like to put into the public domain that NHS Improvement will be having an engagement process once the plan is signed off, and that will include engagement with this Overview and Scrutiny Committee. I realise that might feel unsatisfactory, but that's the nature of the special measures regime that we're in at present.
Can I just come back? I would put on record from my personal, I would hope the committee would think about whether in its recommendations later on to express dissatisfaction of the rules and regulations that have been placed on CHS in terms of sharing information. When health scrutiny was first envisaged and then was enacted in law and still has provisions that all of us work to, the idea that someone would then come to us with a signed-off plan, okay, where someone else has already signed off the engagement strategy, seems to be, it seems to be very counter to what's actually in the legislation, which is that we get a chance to actually look at the thinking of what you have, and then we say this is not sensible, or maybe you should do an engagement strategy separately. We can't make final comment to that because we haven't actually seen it yet, but I would want to put it on record that, you know, and also to the Improvement Agency, that I, for one, would have no issue about pushing for this committee to refer these matters back to the Secretary of State if we feel the plans are either unworkable or have not really consulted the public properly. And the reason why I'm just saying this now, because once we go into Part B, it won't be on public, on record. I am pleased that you're here, and I'm sure, but you know, I'm sure if people were viewing this, it would be very strange that you know, their local hospital trust is under these, which I would see, you know, undue and unfair restrictions.
And I guess just to add to that, and we do understand that it's not your decision, so in a sense we're not criticising Croydon Health Services, but it is, you know, as I've said in, you know, a number of emails, it is you know, a serious issue for us if we, you know, if we're not able to have sight of and comment on plans, you know, before they're final. One thing that I was going to ask in terms of, you know, the offer by the NHS Improvement Agency to consult with us is, obviously we need, you know, we have a set of meetings already set up. I mean, it may be that we need to add another meeting into this agenda because we recognise that, you know, for both organisations, but more particularly for the residents of Croydon, this is, you know, a really important issue. But we wondered what the timetable was for, you know, any potential engagement, because obviously, you know, we have deadlines that we need to adhere to if we're putting an extra meeting in the calendar. You know, we have deadlines that we need to publish that meeting is happening. So,
So our next review, so we've had our first review of our draft recovery plan was on the 16th of September. We're submitting our revised draft on the 29th of September to go through it with NHS Improvement on the 3rd of October. So hopefully at our meeting on the 3rd of October. And I guess it's not for me to speak on behalf of our regulator, but I guess they're looking at it from a plan that they feel is fit to come to you for consultation, for them to review in the first instance.
And I would reiterate...
I'm sure all regulators would always want every plan that comes in front of the public was fit for purpose. But that doesn't always mean it's for whose purpose and whose fitness is making those judgments.
We appreciate your comments. What we would want to reiterate is that the Part B will be an opportunity for committee members to add their contribution, and any comments that we receive we will reflect back to our regulator, and hopefully those can be incorporated into the final plan.
I don't know if this will be helpful then, as a suggestion. On page, it doesn't have a pack page number, to be honest, on the revised report, but the one that starts off with Croydon Health Services NAH Trust, and it's in white, okay? There is some information in there that is effectively, that has been as a Part A area, and I just wondered whether, even though you may have a more detailed presentation for Part B, but whether you could at least speak to that section in Part A following on from the CCG's, I'm assuming, are okay with their presentation in Part A, because I don't think they're under the same restrictions.
But the answer is definitely yes to that. We plan to put all of the information in this report into the public domain, and we will answer any questions on that as far as we can, as long as it doesn't stray into issues which we'd like to reserve for Part B.
I'm just, having kind of dealt with that end of... so is the CCG happy to do their presentation in Part A?
Absolutely, in terms of the PowerPoint presentation and the special measures paper. Absolutely intend to present that in Part A. Quite right, the PwC report has to stay in Part B, and also the more detailed paper also would need to be in Part B.
So, shall we do your CCG presentation first? Because we can turn the lights off, we can have the presentation. Oh. Okay, we haven't got it available. Okay. Okay, so... no.
Chair, if I make a suggestion, so the PowerPoint presentation does no more than summarise the paper that's actually already in the papers. So I don't think anyone is lacking any information. I will talk to the presentation, and if there are questions or issues that I don't cover, I'm happy to answer questions, but it does no more than cover that paper.
I think it's probably helpful if you go through your presentation, since we had you first on the agenda, and then if Croydon Health Services could talk through their Part A paper, because I think there is going to be some elements of, you know, one thing's going to impact on another. So I think it's probably helpful if we then ask questions generally on both of the presentations as the Part A thing. And as I say, if we start straying into Part B, then obviously let us know, because sometimes the mind just starts whirring and, you know, a question leads to a question. And then, you know, once we've dealt with those issues, then obviously we can, you know, we can move into Part B, and we can deal with the more sensitive issues from there.
So if I kick off walking through the presentation. So the first slide is around special measures, and the joint context for both Croydon Health Services and the CCG is the document that was issued on the 21st of July called the Strengthening Financial Performance and Accountability 2016-17 that was issued by NHS England and NHS Improvement. The slides here take you particularly through the CCG element of that, but that document issued on the 21st of July is the trigger for the special measures arrangements. So in that document, Croydon CCG is placed in special measures specifically because of its forecast financial performance in the first quarter of this financial year, where we were reporting a 9.9 forecast 9.9 million deficit against our stated control total or permitted deficit of 4.2 million. And on that basis, for being, I think, the only CCG in the country to be off trajectory at that point, we were placed in special measures. The specific measures that are in place that we are directed to produce and implement an improvement in financial recovery plan, that we are to improve our governance, that we're to deliver the recovery plan, and lastly, to develop leadership for the CCG that's consistent with shared management arrangements to support implementation of the STP, which is short for the Sustainability and Transformation Plan, and that references to the collaborative NHS working across South West London. In response to those measures, we have commissioned jointly with NHS England an independent financial and QIP review, and secondly, a well-led governance review of the organisation's governance structures. Those reviews started, the financial review started in July, and there is an interim report that is available in the private part of the meeting. But there are further elements of that work that we completed in September. The well-led governance review is being completed this week, and we're expecting first draft report and conclusions at the end of this week. We also feel it's important to note that in that document on the 21st of July, the 2015-16 annual assurance framework results for CCGs were produced and published. Croydon CCG was placed out of 4 tiers of rating. We were placed in the 3rd tier, requires improvement, along with 90 other CCGs in the country. And we did receive a good rating for the well-led criteria. In terms of our historical financial context, that's contextual to the position that we find ourselves in Q1 of this financial year. Croydon CCG was established in April 2013, with inheriting a significant financial challenge from predecessor organisation, which was Croydon PCT, and also as a product of the changes in the system at the time in terms of establishing and separating off specialised commissioning and primary care to NHS England. In December 2013, it was confirmed that Croydon CCG was funded just over 10% below target in its establishment year. And that target is a needs-based target derived from census population data and various needs variables that are applied statistically across the country. So from establishment, Croydon CCG has been in financial recovery and has adopted that model as business as usual. Although being funded below target, there's nevertheless the requirement to improve efficiency and effectiveness within the system, and there certainly was no promise of additional funding, certainly from historical experience. The CCG has delivered an improved financial position in each of its previous 3 years and has delivered 35 million QIP, which is NHS jargon for efficiency savings, but it is around quality improvement, innovation, productivity, and prevention. The current financial context is that 5-year allocations were announced in January 2016 and did include significant additional funding for Croydon CCG, well above the national average. The effect of that funding and funding received in the prior year was that the distance from target position had significantly reduced from the 10% position to around 3.71%, which within NHS England funding allocation policy falls within their plus or minus 5% tolerance, i.e. outside that tolerance you can expect to receive what we call pace of change funding. Within that tolerance there would be very little movement. Based on our 5-year model, and because we've been in financial recovery mode, we've been running forward financial plans since inception. Had that been the only change and allocations had flowed through, we most certainly would have been able to meet our duties. But in 2016-17, there were a number of what we call business rules or financial planning assumptions within the NHS that also changed and created unavoidable commitments. Commitments that had to be met and can't be avoided in the short run. Consequently, the overall requirement to meet statutory balance in response to the allocations we've received, the expectation from NHS England is that we achieve statutory balance in 2017-18 and have a permitted deficit of 4.2 million in this financial year. The following slide highlights our performance historically and highlights how we have reduced the deficit since 2014 over time. However, it does highlight in 2016-17 significant financial risk and reflects the forecast position we're reporting to NHS England and publicly at Q1. Saying that, you can see from the percentages on the table, the percentage deficit we've been running has reduced over time, and certainly was planned to be year on year smaller. However, clearly with the forecast at this point in time, we do have an in-year challenge we are seeking to address. In managing the 9.9 million position and seeking to work towards NHS England's target, we are having to work to an 18 million savings programme to deliver that. In terms of how have the financial challenges of the CCG developed and been exacerbated over the last couple of years, there are about 6 points there that are highlighted in terms of the challenges we face. Although we have received above average funding allocations, we have also had to incorporate a number of expenditure or funding commitments within that. For example, CAMS, Child and Adolescent Mental Health Service Investment, IT services for primary care have been absorbed within that growth allocation. Changes in business rules, and in some cases, many of the business rules interact how CCGs pay for care provided by providers such as Croydon Health Services, and there are a number of arrangements around how emergency care is paid for that have changed over the last 2 years, that have meant increased payments for the same activity to the CCG. We've also had transfers in establishing the Better Care Fund, that although the aspirations and the goals of the Better Care Fund are absolutely in the right direction, the way those funds were set up did create a deficit position for the CCG on transfer. Requirements to fund mental health services and meeting mental health parity of esteem, so maintaining growth in mental health services at the same rate as our allocation rises, has created additional commitments, meaning we can't take the increased resources to the bottom line, and increased demand for services, emergency care, outpatients, continuing health care, prescribing, etc. We all have to manage. And slide 7, financial performance, what's changed? In the first 3 years the CCG has been operating, certainly the context of being below target and documented below target and being outside the 5% tolerance has meant that there has been a measured approach from NHS England in terms of agreeing deficit targets, reducing deficit targets, but deficit targets nevertheless over the last 3 years. However, with the allocations made in January and the clarity that in 2016-17 we were within the tolerances, I guess the exceptionality or specialness of Croydon CCG what was removed, and the expectation immediately on the CCG was to deliver and to be managed in the same way any other challenged CCG would be when they were within target. Although we are within the 5% tolerance, given that we are the largest CCG in London, 3.71% does account for £18 million, and that is significant to us. And I think the fact that we are the largest CCG makes that figure more material. Nevertheless, we do have the 5-year allocations, and we can see we are not getting any more resources going forward, and we do need to plan on that basis. We have secured financial assurance on all our previous year's plans, and we have continued to benchmark the opportunity to redesign services and to deliver services more effectively. As we have delivered over time, there is a reducing QIP opportunity. We know the benchmarked opportunity has never been equal to the financial gap that we face, meaning that we have to look for more and more transitional solutions, including the outcomes-based commissioning work that you will know we've been working on with Croydon Health Services and other partners in the system. We've recently procured integrated urgent care services to try and redesign the way those services are provided, as well as working collaboratively with South West London to deliver change that would reduce the financial gap that we have. At our September governing body meeting, the following couple of slides are an extract from what we took to that meeting. As I mentioned earlier, we've been operating in financial recovery mode since we were established. We've had a financial challenge to address. We now need to step that up a notch as well to be able to rise to the challenge we face now. The items that are listed on the next 2 pages are the things anyone would expect to see an organisation in financial challenge to be doing. We already have strong arrangements around governance, project management office processes to support the organisation and capacity within service redesign teams. But to strengthen that, we're certainly tightening existing financial controls. We have secured additional financial recovery turnaround capacity in terms of a financial recovery director who will be starting full-time next week. We have an internal financial recovery action plan document that is overseen by the Finance Committee to ensure that we have a continued grip both on business as usual functions, whether it's financial control, contract management, but also in responding to some of the emerging variances we see in year and delivery of projects. And a key thread of that is GP engagement. On the next slide, highlighting the areas of our 18.4 million recovery programme that we are committed to this year. We started the year with around 12 million of that programme documented and have been under both internal and external pressure to identify the remaining 5.7 million. The threads across this, in terms of how we're going to deliver that 18 million, is continued delivery of our QIP programme, our clinically led service redesign in any case. We need to continue to deliver our longer-term transformational projects. There is always the risk that we get completely consumed in short-termism. We do need to maintain those longer-term threads as we go into the second, third and fourth years of the 5-year plan. We need to release management costs through collaborative commissioning, be that through greater efficiencies with our commissioning support unit or across South West London. Clearly we need management resources to deliver change, but we need to absolutely do that at the most optimal level. We clearly need to enforce compliance to existing treatment policies and criteria. So we already have South West London policies on procedures of limited clinical effectiveness and have worked collaboratively to establish those. But there is the need to focus on both enforcing those policies and ensuring they're being adhered to, both in terms of primary care and secondary care, but also reviewing that those thresholds are up to date and current and best practice. Working with partners and providers to deliver better value from existing contracts. Basic value for money, it goes without saying, but clearly a renewed focus on that. And I guess the last point is indicating part of why we're here today. So there is a shift in emphasis, clearly, from clinically led, longer-term, quality-led QIP to the need to really scrutinise, in the first instance, value for money, clinical effectiveness, but also considering some element of prioritisation, recommissioning, decommissioning, particularly where procedures or services are of limited effectiveness. In terms of how we move forward with specific proposals, clearly that the CCG, in response to the challenges, has been considering a range of options, and the paper on special measures goes into some more detail, which I'm happy to allude to, but you can see within that paper a structured approach to different layers of, if you like, expenditure reduction. But also we've been clear in that paper where there are some no-go areas, either because of the importance to the population, or because of the very short-run nature and the very quick unintended consequences that would arise. So, for example, in the paper there are examples of very short-run measures that some CCGs may propose would be simply extending waiting times on elective care. It would be a short-run measure that might deliver some financial benefit in the short run. However, very quickly, many of those patients would present as emergency cases, and to any extent, they all ultimately need to be treated. So there are a number in there. We also highlight child adolescent mental health services as a key area. I think there's probably been scrutiny before as an area that needs significant strengthening in Croydon, is also quoted. And there are a number of other items. We have highlighted in the detail of the paper that as we go through the process, we will inevitably identify some areas that require recommissioning, decommissioning. Those decisions haven't been finalised yet. The slide pack highlights the process around engagement. So we would most definitely be looking to pre-engage with stakeholder bodies across Croydon around areas of recommissioning, decommissioning, reprioritisation. We will be taking detailed equality impact assessments to understand which initiatives represent the greatest risk or impact. And off the back of the engagement we've already done across Croydon, we will form a view on those areas that it would be appropriate to engage or consult in further. But we would expect to come back and share that with you once that understanding is developed further. We think we've got a good track record of engaging with Croydon, particularly if you take the example of the urgent care model that is recently run, and clearly we would, if there are areas of change and redesign that needed that level of engagement, we would of course be doing that. And I think that probably concludes the paper. The detailed paper, again, emphasises how we would engage in a relatively short period over the coming month, in effect, and would be looking to come back to scrutiny again the next time it meets.
Thanks. Michael, John, who's going to lead on this?
I'll kick off and then I'll pass across to John. What I want to do was initially kick off with a little bit of reassurance to committee members, particularly those committee members who have been on part of this journey with us for the last 4 years, in terms of the substantial improvements that CHS has undergone in terms of first safety, which was our #1 priority to address the deficits there, followed by quality, including patient experience, and then critically performance. And on all of those indicators, CHS has improved significantly and substantially and is not where we want it to be, but is certainly above average for London against all of those criteria. In terms of our work with NHS Improvement in developing the plan, they recognise the level of improvement that CHS has undergone, and they want to ensure that we safeguard those improvements. So that's the area of reassurance. In addition to that, they are aware that the Trust has been working with colleagues, including the local authority, but also the CCG, the Mental Health Trust, and the third sector, and critically, most recently, the GP Collaborative, on developing future plans. They are aware that we need to make sure that we don't compromise the long-term sustainability of the Trust by going for a number of short-term quick fixes which might undermine that. That said, we do have a substantial challenge. I'm going to provide you with a little bit of a background to what financial special measures means, why we've been placed in it, and then I'm going to ask John to take us through other aspects of the paper. At the beginning of the financial year, the Trust set a budget of 39.8 million deficit for the year ahead. That was based upon bottom-up budgeting from each of our frontline services on what we thought was needed to deliver a quality service. Within that plan, we identified that there was £14 million of savings to reach that target that we needed to achieve. In June, we were asked by NHS Improvement to adjust our control total down to 32.8 million, about 5% of our overall turnover. At the point they asked us, we had only identified 6 million of the 14 million cost savings, and we also had around 10 million of what we called long stop items, i.e. areas within the contract that we hadn't yet resolved with the CCG. On the basis of those substantial risks, we were not able to say to NHS Improvement that we could meet the new revised control total. The risks were too great at that point. We did not say to NHS Improvement at any point that we rejected that total, but we said we could not commit to being able to meet it at that point. On the basis of that, in July, both NHS England and NHS Improvement set about what they called a major reset of the system. As part of that, because we hadn't been able to accept the control total, the Trust was placed in special measures, financial special measures. What we have to do to satisfy the financial special measures regime, or FSM as I'll refer to it, is we need to provide NHS Improvement with a full understanding of the deficit, particularly if there are aspects of the work that we're doing which are not being fully funded by our commissioners. We need to demonstrate a plan which includes, particularly around productivity gains, how we can address that gap, and whether or not there are activities which the Trust should no longer undertake as we move forward into the future. So that's the challenge we've been given by NHS Improvement. We have been working on the plan since July, when we were placed in special measures, and we have had two formal meetings. And as John indicated earlier, we have a third meeting with NHS Improvement and with the lead from NHS Improvement on Monday of next week, where we'll be presenting what we hope is our final plan. There are three outcomes from that particular meeting in terms of the financial special measures regime. The first of them is that they do not think that the plan is credible or that the organisation has any hope of delivering it, in which case alternative scenarios will be looked at by NHS Improvement outside the gift of the Trust to work on those. So it's effectively complete loss of autonomy for the Trust. The second option is that they think it is a credible plan, but they need further reassurance about the capacity of the organisation to deliver that plan, and that will involve a period of monitoring by NHS Improvement to see that the plan is being fully implemented. The third element is that the plan is so strong and the level of confidence in the capacity of the organisation to deliver that plan is so great that the organisation is moved out of financial special measures. We suspect that the second one is the most likely outcome for CHS, but at this stage we do not know that. That's the nature of the regime. I'm going to pass across to John now to talk us through what the deficit is made up of, so the key components of the 39.8 million, the key reasons for that deficit, so why is CHS running a deficit at that sort of scale? The actions that we've taken immediately to control some of the expenditure, and then I'm going to ask him to outline the way in which we have worked to develop the plan to close that gap and find the £6 to £7 million that needs to be found. That is the point at which we will not be able to talk about the precise details, but I would want to reassure members of the public that the journey that we have undertaken in terms of safety, quality and performance is recognised by our regulator, and we are not being asked to compromise the progress that we've made in those areas. John.
Thank you, Chairman. So our ask is to reduce our deficit from 39.8 million to 32.8 million, and if we're successful in doing that, we can then become eligible for 9.8 million funding from this fund called the Sustainability Transformation Fund that NHS Improvement has, that it potentially can give to providers to reduce their deficits further. So there's the carrot and the stick. The carrot is if we're successful in delivering 32.8, we may receive, if we also hit our national standards of care targets, we may receive another 10 million to in effect get the deficit down to 23 million. That, what they call the STF funding, Sustainability Transformation Funding, is then available for the following 2 years. Not necessarily at the same amount, but there is. So there's the carrot in terms of hitting the NHS Improvement control total. Just turning to why have we got a deficit of 39.8? As you're aware, the vast majority of NHS providers had a deficit in 2015 and into 2016. I think it's at least 90% of organisations that have an acute hospital have a deficit planned. Our deficit is slightly higher than others, and of course we didn't sign off our control total in June, hence financial special measures. So the first thing is, in tackling our safety and quality issues, we today have 280 more clinical staff than we had in 2013. So just to remind you, in 2013, we had 2 registered nurses on a ward at night looking after 30 patients. That is no longer the case. We had a skeleton staff of doctors running the hospital at night. That is no longer the case. Just 2 examples. In that period where we've gone from having below average staffing to what we think is average, clearly where NHS Improvement is doing work with us to go through, are we at average now? Are there any areas where we're above average, in which case should we come back to the average? It has been difficult to achieve the level of cost improvement savings that we would have needed to achieve to have a lower deficit. So each year for the last 3 years, we should have achieved a 4% cost improvement target. Broadly, we achieved about 3% a year. So, but if you add those 3 years up, that's a shortfall in the region of 6 to 7 million. Secondly, we've gone out to recruit 280 extra clinical staff at a period when the whole of the NHS has decided that the average needed to be increased. And at a time when NHS, 6 or 7 years ago, Agnello will remember this, decided that we needed fewer staff for hospitals, and therefore reduce the number of training places for nursing and medical, etc. So there's been a shortage of supply. So we have increased our establishment by 280 at a time of shortage of supply. The cost of our that we've spent on agency staff has therefore rocketed over 2 to 3 years. So in 2014-15 we spent 15 million on agency staff. 15-16 we spent 24 million on agency staff. So that's a key part of our deficit. So there's those two aspects of workforce that really are key contributors to, they're the biggest contributors individually to our deficit. So overall, if you put that together, a good 15 to 20 million of the deficit is the knock-on impact of increasing the workforce while not reducing our cost base enough at the same time, and also the fact that we've had a premium for agency staff. Ideally, we'd have liked to receive a little bit more funding along the way from our commissioners, but we recognise where they are, and I wouldn't labour that that's a major factor within our deficit in terms of staffing, but it is a bit of a contributor. We've also changed our systems at the same time, our IT systems. Initially, that was all funded by an organisation called HSCIC, which is Health Service, basically the information part of the Department of Health. They held those contracts nationally. They were devolved to trusts on the 1st of October 2015. We inherited a £3.5 million contract direct with the supplier, but that funding wasn't passed down, and that was a cost pressure to us. In addition to that, we've had to increase our staffing on admin and clerical staffing to run the system. So overall, we've got a cost pressure of 5 million. We have got a benefits realisation programme, but it's slow to get going. We're just this year getting the first fruits of that, and that's part of our technology optimisation programme. Over the next 2 years, we would look to have dealt with that cost pressure and actually reduced our costs below that. That's taking the big leap from being having a lot of paper to being paper light to being paperless. So we need to start that journey and therefore reduce our health records costs, and also the administrative costs that we have that run the system by running it more smoothly. Final area just to raise is that, like the CCG, we have lots of benchmarking reports overall on productivity. There's something called Better Care, Better Value. I know it sounds like a reconfiguration, but that NHSI has got a new benchmarking booklet, data, which is called that. Nothing to do with South West London, it's national. And of course, they've pointed out to us areas where we're doing well and areas where we're below average. And of course, if we do better on the areas that we're below average, we wouldn't quite have the deficit that we currently have. So an example of that is, as at today, we have 270 patients with a length of stay of more than 5 days. That's a bit above the national average. Our do not attend rates for outpatients is 11%. The average nationally is 8%. So they're also contributors to why we've got a deficit at that level. So they're the key components of the deficit. What are we doing about it? The first thing is we're well on the way to having a cost improvement programme that approaches 14 million. As at today, it's 13.2 million. I've left my colleagues behind. They're working on schemes from the last couple of weeks with directorates that finance and our PMO are going through. So hopefully the 13.1 million will come up closer to the 14.1 million. That will we then have to stretch that a further 7 million. So we've got a series of mitigations, all about, in effect, stretching down our agency costs further. We've ratcheted up our controls. So one of our responses to how we're going to do this, of course, we had financial controls. We've got controls in place for who can book a member of temporary staffing. We've ratcheted all of that up. We've looked at all our discretionary spending. We have a panel of 3, Director of Nursing, Finance Director and my Deputy, and any requests for discretionary spending then come to me. If it's above an amount, I take it to the Chairman. Nothing's come to me in the last 5 weeks to sign off. So that's having an impact in terms of discretionary spend. Just to reassure you in terms of both our cost improvement programme and also our mitigations, everything that's proposed has to go through every action that's proposed has to go through our clinical cabinet that's jointly chaired by our medical director and our director of nursing. The clinical cabinet had its most recent meeting on Monday to go through the areas that we've come up, the new actions that we've come up with over the last couple of weeks. There's a quality impact assessment on every action that we have. In terms of saying yes, no, or do it in a different way, and that happens prior to putting a pound sign onto our recovery plan. We have also engaged our staff. We have over 70 ideas from our staff in terms of these are ideas of how we think we could reduce our costs. A good example of that is some of our staff, a couple of our staff said we have yellow bags for clinical waste, black bags for non-clinical waste. And they had spotted that some of our staff are putting non-clinical waste in clinical bags. The disposal cost of a yellow bag is 11 times higher than the disposal cost of a black bag, I think for obvious reasons. And therefore, that idea generates potentially a part-year saving of £100,000. We also have, our staff have raised a number of ideas in terms of how we could use IT better. And again, if you look at all of those together, including helping us reducing DNAs in outpatients, that comes to another £100,000. So we've got at least £200,000 of ideas from staff, but we've also got a number of their ideas that we're also taking forward. We've met with the consultants, and the consultants have come up with ideas as well. They're part of the plan. We've also met with the trade unions. The trade unions have suggested ideas. For example, they've said, why do we do internal recharging? What's the point? Yes, it means finance know more accurately, you know, what should go to which division, but what's the point of doing that? Why don't we cross out the recharging team and save money on that, as just an example of some of the ideas that have been generated. The next stage that we're going through is looking at what are the risks to delivery of all those items that we're coming forward in terms of mitigations to stretch our savings targets and to get us down to 32.8. And that's the bit that we're working hard on over the next couple of days. Clearly, the easiest way to mitigate risk is to find more. So we're doing that as well. So the sorts of things we're looking at is how do we avoid our integrated adults directorate spending all their time in the A&E department working on emergency care flow issues over the winter and not being able to devote enough time to delivering the delivery plan. That's a good example of the sort of risk that we're looking that we're looking at. We also then move on to 2017-18. So that's the final component of our recovery plan, and we have to report back by Thursday with our first view of how far can we go next year in reducing the deficit further. At the moment, we've proposed a cost improvement programme. This year it's 14 million, next year of 12 million, but added to that is the full year effect of some of the savings that we're looking at now, which would push that up towards 15, 16 million. And that's the next part of the debate. One thing that did come out that is in the public domain last Thursday is the planning guidance for the next 2 years. It's on the NHS England website. Chairman, you might want to look at that at a future meeting. All NHS organisations, the CCG and ourselves, are going to receive a letter potentially in early October that says, here is your control total, financial control total for the next 2 years. Work up a plan that enables you to deliver on that in the following weeks. Also consider whether you wish to, within your STP, which for us is South West London, whether you wish to have a joint control total across South West London to manage risk, or within Croydon, do you want to have your own joint control total between the two of us? I think that's something that's worthy of consideration in terms of how we manage risk and how we can have win-win rather than win-lose with ourselves and the commissioners. But clearly we'll need to go through and assess all of that. And that's for tomorrow. The first thing we need to do is have a plan for 16-17.
Thank you. So shall we try and do some questions in part A? Andrew?
Yes, certainly being very respectful of the purity of Part A, I'd like to ask one question. Could you just tell us actually who measures that underfunding measurement? It's a government measurement, isn't it? And I wonder who that is.
So it's NHS England.
Yes.
Does the calculations. I mean, there have always been formulas in the NHS since it was established in terms of trying to determine what's a target allocation of resources, and it's been iterated over the years. When CCGs were set up, initially there were no formulas. So, April 2013, nothing existed, but it was developed and it has been iterated over the last couple of years. But it's effectively a combination of census data, but also linked to GP population data, because GP population data is more recent, more accurate. It probably could be 12 months out of date, but it's more recent than the census data. And it's built up from sort of various regression analysis on statistics, correlating need and demand with various variables. I think it's York University. They do outsource the statistical analysis in it.
Very good. In terms of the numbers that have been provided by the CCG, does that cover what the underfunding is for the hospital as well? Or is that separate? And how much is that if it is a separate figure?
I think it's a separate concept, might be the best way to say it. So in terms of CCGs are funded to provide care for for a defined population, and so that the target allocation formulas are just generated for CCGs for their population. In terms of for providers, there are different benchmarking or targets, if you like. I mean, one target in a way is the payment by results regime, although given the number of providers in the system that are running a deficit, clearly that one's running out. But also, I think in recent times there's been the Carter Review, etc., that provides benchmarking across providers of similar size, capacity, case mix.
What I would say is that actually, as we move forward as both the Accountable Provider Alliance but also the Croydon Alliance, we will be moving to a system which is much closer to the capitated system that the CCG is under. So instead of being paid for treatment interventions, which is the majority of our funding at present, the Accountable Provider Alliance will be paid for the population and keeping it well, which will parallel the way in which the CCG operates, and I think will make it much, much easier for us to work as collaboratively rather than adversarially.
The CCG paper refers to a number of consultation activities. What would the nature of those be? Particularly as the whole process already starting very late in terms of being given notice to both these organisations in terms of trying to struggle back up to hitting an increased target. Is it going to be very practical for you to be able to consult, and what is the nature of those consultations?
So I think we provided more detail in the Part B paper. Not that there's anything I think particularly Part B about our approach to consultation. I think we'll be building on the approach we've taken, for example, through the urgent care engagement in terms of reaching a breadth of Croydon population and some hard-to-reach groups. We clearly need to identify the key issues that need focused engagement on them. Not all issues. For example, if we're simply looking for better value for money, recommissioning existing pathways, we wouldn't be looking particularly to engage except for what we would do through the normal commissioning process. But where there are issues around reducing provision or decommissioning, clearly part of that is identifying the populations or specific subgroups of the population that would be affected by that, and then specifically engaging or, if appropriate, consulting with those groups.
So it sounds like it's not going to be a very broad public consultation, really, then, is it? So definitely we're proposing a targeted consultation on the specific areas. I think there are 5 or 6 areas that we would be focused on, but nevertheless, the broader themes of, for example, the level of detail in the Part B paper will be going in the public to the governing body. They will be in the public domain, and we will take that broader paper out for engagement as well.
I'll try to keep my questions brief. On page 5 of the pack, I think, no, sorry, page 6 of the pack, so your presentation, you talked about some of the drivers, the financial performance. They seem to be sort of national drivers that every CCG is dealing with and tackling. Have you got any views on, because we're in quite a unique position, aren't we, in that the CCG and the Croydon Health Services are both in special measures, and I guess that probably creates its own problems because they're your key customers, as it were. So that's going to create more financial pressures. But I just wondered, how are we unique in that we've got into this position where both organisations are in special measures, because they're national drivers, but I didn't get a feel of what some of the local drivers that's got us into this position is.
So if I cover up maybe a bit about the population generally, which you will no doubt be familiar with, but there are, although there are target formulas, there are elements of the local population that aren't picked up in national formulas. So the fact that we have significant numbers of care homes and nursing homes in Croydon, 137 care homes, I believe, and 40 to 50 odd nursing homes. And for health services, what that drives is an inflow of people with health needs that are above the average for whatever age group that's coming in, who then re-register locally with local GPs and become deemed to be the local population. We clearly have the Home Office on our doorstep, and that certainly drives some particular issues in the population, whether it's with the unaccompanied asylum-seeking children, a level of asylum seekers in the local community, although the data on that suggests that is reducing as government policy moves. We also have, a significant BME population, and that certainly drives some of the issues. It's certainly a big driver in terms of use of mental health beds in Croydon. Is certainly a big factor there. The other general comment I have, you're right, these themes might read like any other CCG. What I would say is some of those population characteristics drive a common theme across the two organisations, which is there is a very high level of emergency and urgent care, accessing those services in the system as opposed to planned care and a lower level of need. And that certainly, these themes that for example, the business rules issue and the Better Care Fund, the fact that we have a very high emergency care throughput and workload means these general issues nationally certainly have had a much bigger impact on the CCG as a local commissioner, and there's certainly some of the issues that are challenging the CHS in terms of operationally responding to that demand. And the other issue I don't think we understand well enough, but are seeking to understand, is almost the turnover of the population, if you like. So the population grows on average around 1% per annum, but actually within that, be it with the international net immigration or just generally the house building in the community, that there's a much higher turnover of patients, which would increase demand both on primary care, but also unknown patients to secondary care and mental health services.
Could I just add, 'cause I think that Mike's touched upon it, the biggest driver for us is actually the profile of emergency care, and within London we have the highest per head use of emergency care in the capital. That is something to do with the nature of the population that we have, as well as challenges around access to primary care. The hospital is located in the north of the borough, which is the most deprived part of Croydon. It's also the part of Croydon with the most rapid population churn as well. So people don't necessarily become embedded in their community, register with their GPs. For many, A&E is there. I think the other issue, which I know that the Council has raised on successive occasions, is the cumulative effect of the underfunding of Croydon CCG since its start in April 2013, and the fact that it was in a unique position of inheriting debts from the PCT, which set it off on a particularly challenging course. That is an issue which I know councillors have raised in respect of the council's own funding from central government and the revenue support grant and the way in which the formula operates there. That may have that will have certainly added to the challenge that the CCG has, and consequently we have as a trust, in the sense that we would reasonably expect to receive 40 to 45% of any increase of funding that the CCG has.
Just going to say it's 7:45 now, and I'm keen that we, in the next quarter of an hour, get to the Part B items, because obviously there's a lot more detail there. So I'm just going to ask everyone to keep their questions short and their answers as short as possible, so that we can get on to the meat, if you like, of you know, what's in these papers.
Just then, I'll skip to just one very quick point of clarity on the presentation. For the Croydon Health Services, if we hit the target of 23 million this year, then you get your carrot of 10 million. That will take it down to 14 million. You said then cost savings of 12 million the following year. So are we saying in 2 years' time we might be out of deficit if we get the carrot following that?
The figure is 32. If we get down to 32.8, we receive 9.8, which takes us down to 23 this year. We then we're not in a position to say what next year would look like yet, but we are working up that plan, and clearly we then need to work with our CCG and check that our plan is aligned with theirs, because they have some significant challenges as well. Did you want to add anything?
No, your question is not out of line with the question we get from NHS Improvement, so it's in line with the challenge that they're setting us.
I just wanted to check how the actual financing works. Obviously, the numbers are quite big in terms of deficit. I'm assuming that's a sort of a debt that you have with NHS England, and you're not actually borrowing money or running up an overdraft on this, but I think it's just be good to have some clarity about how that works.
So there's two different regimes in place. So if I talk about the CCG regime, so what we're set each year as if you like, an expenditure cap or an expenditure target, which we're clearly exceeding. Separately, we receive what's known as the maximum cash drawdown. Now, in reality, certainly for the last 3 years, the maximum cash drawdown has fully funded, in cash terms, the deficit position that's been run. So there isn't some sort of accumulating shortfall with suppliers or anything like that. That with CCGs, the cash flow, the cash is released to CCGs in whatever profile the CCG requests it during the year. The only month that becomes a critical issue is in March. The process for agreeing cash or refining that maximum cash drawdown for the CCG happens in October each year, well ahead of March. So that's the process we're in. I guess the reality is in the system overall, this Croydon CCG has been accessing the cash generated from other CCG surpluses in the system. CCG surpluses, are not spent. There is an emerging tension in the system that there are hard times for all CCGs, and those CCGs that have accumulated surpluses in the past are looking to draw those down. But it's not a formal debt arrangement, if you like. It's a process that's managed by NHS England, and the way they're managing that is clearly putting us under pressure and scrutiny to achieve the break-even position first, and then get into 1% surplus, so that process can be reversed. But there's no risk to the CCG cash flow in the short run for this year.
And our regime is different. We have to put in an application in effect for a loan from the Treasury, which comes with an interest payment attached to it. So you have to factor in how you're going to cover that interest payment as part of your recovery plan. The loans are agreed as your financial plans are agreed. So clearly, if we can get a financial recovery plan at 32.8 million, that helps us in getting our request for cash to cover the deficit signed off by NHS Improvement, who put in an application to the Treasury. The potential funding of up to 9.8 million in addition to hitting the 32.8 is cash. So there's a carrot there that would reduce our loan to a request for 23 million.
Just want to pick up a point I think that Kathy raised, and I think Mike then followed up on, which was about how well you work together. Because in instance, you are working to two different organisations' strictures, but you are symbiotic. You can't live without each other. You can't go off and get funding from Sutton. Well, you could, but and vice versa. If you don't have a hospital on your doorstep, the costs of provision of services. It may be that we'll find out more, but I'm just thinking through when we've looked at lots of issues in the past, and sometimes about the hospital, and I'm just not hearing at the moment sort of where you, as two organisations, are looking to find those synergies, or where there are, you may have competing tensions or competing ideas in the sense you're pulling in separate ways. So you could just give a quick overview about how you together are working on this. And obviously we've got the council involved slightly in this as well. So it's actually, there's almost like that three-well. And of course, I look sometimes at health and wellbeing board papers, and frankly, I think, that's a place where nothing really happens at one level because there's so much paperwork going through there. I know lots is actually happening, but so just tell me how maybe even ask the question, out of 10, where do you think you are in terms of your partnership working?
I think one thing we've done over the summer that is going to help us, I'll see if Mike responds positively or not, is we've formed a joint financial improvement board, which consists of the two chairs. We each have a finance committee, non-executive director chaired, so they are the co-chairs, take it in turns to chair. Mike, myself, Paula Swan and my finance director are the core members. We can then bring others so that we can share with each other. It's a confidential meeting, but we can share with each other, these are our emerging plans for this year. How can we work together in terms of next year, in terms of how do we move from a transactional nature to a transformational nature without one side copying all the risk at the benefit of the others. So I think that is a good start point. The second thing we have is our working together on the over 65s in terms of outcome-based commissioning, both provider and commissioner, and it brings the council in. We're in it together, and That hasn't started yet, but it's hopefully due to start in 2017-18, and I think that that is the major, my chairman mentioned it, Mike, earlier, that is a major opportunity for us to really move from transactional to transformational. Some of this may well, a good example is it's not just about us and the CCG, there's things that we think we could do quicker in the hospital by working smarter with social care, and that's part of our recovery. And it could be that investing in social care is, and getting people to be able to leave hospital earlier and having fewer admissions. We save more money in the hospital than that investment in social care, so that's a net gain. Now, it's not been easy with the current system to make that sort of change, and hopefully in the future it will be, because we'll look at it as one big pool.
As John tripped off those examples, they were the examples I was going to give in terms of, as you said, starting with the Financial Improvement Board. I mean, it is a challenging system with big financial deficits, and regulators driving, from their perspective. We do still, and you're quite right, we still need to come together as best we can and better than we've done before. I would add in South London and the Maudsley as well. So we've got clearly a relationship here, and they're part of the OBC, so they're already in the ring. But certainly there are, around adult mental health services and demand for the over-reliance on secondary care beds, etc. There are real issues there, and the interplay with A&E, with psychiatric liaison, etc. Actually, we're bringing South London and the Maudsley and social care together with us is also part of the agenda as well.
To follow up on that, just very quickly, we've had over the years at this committee many different discussions of integration and about the need. Agnella has even talked on them, I'm sure. And you're talking about you having these joint boards, and nothing I'm disagreeing with, but I'm just not getting a sense that this integration agenda is sort of really flying at the moment. It's sort of, you're still having sort of these tentative discussions. You're setting certain things up. I mean, has someone ever sat down, or have you all sat down in the room and said, you know what, there are 6 things we should be doing? Or are we doing like one person approaching one group saying, we need to have the discussion, I'll show you this, if you show me yours, that type of stuff? Is it something on all of your agendas that each one's saying, how are we going to work closer together to save money and provide better?
Yeah. So we are doing that. But I guess the reality is, with the current system structures, the current objectives and incentives to each individual governing body or board that each organisation works within, it is a real challenge. If it was easy, it would have happened before. We're absolutely trying to work through those barriers, if you like. I think the OBC is our serious attempt to bring everyone together in a way that hasn't been done before. We do need to find the win-wins in the system. I think what we're facing is probably a scale issue as well. The scale of change that's needed represents, in a fashion, more risk as well, that we need to embrace but engage in as well.
For a second, both the clinicians on both sides are working together as well. We've had joint workshops on musculoskeletal recently, GP open meeting with the gastroenterologist, and on different scales, looking at what we can do in terms of improving the quality. Because, I mean, let's face it, the bottom line is we're in a rock and a hard place, both organisations. And if you had an equation where you got demand on one side, funding and lack of staff on the other, trying to balance those two is not easy. And I think the financial experts on both sides have been working hard to try and find solutions. And as clinicians, we've been trying to help support that, which doesn't result in decommissioning. So we're all aware of where we are, but those are the key elements in the system where there's the issue of funding and the issue of staffing, which is not necessarily going to improve in the short term, which is driving some of the changes that we're trying to make. And I think both organisations, with SLAM, with the GP Collaborative, with Age UK, coming together with OBC, and certainly working collaboratively with the urgent care as well, in terms of trying to do things differently. And I think, given what we have, we are working as well as we could. There's always more that we could do, but there's a lot on each other's plates at the moment.
Darren, I was just going to ask if you had a question in this. Okay.
Just to say that the general public has no sort of perception that their local NHS is in deficit. It wouldn't actually hurt them to know that. It might make any engagement a little bit easier if they understand, the background. Just to say, Bart's Health are actually, they've got the largest deficit in the country by a country mile, but they're making that, widely known. So getting that information out in the public domain might not actually be a bad thing. And the other thing about equality impact assessment, I've heard the word quite a lot, but if some of these cuts do actually happen, of course it's going to lead to regional inequalities. We've got to look at that. Okay? Thank you.
Yeah, a couple if I may. Reference has been made to outcome-based commissioning for over 65s, and I think you just said 2017. So presumably the delay is impacting on your opportunity to obviously work together and produce more savings and efficiencies. So I didn't know whether you were able to say any more about that. And also in the paper you talk about cash flow and debtors, and you're being more robust. Could you give me an idea of how big that is and how more robust you can be to make sure, and what impact that would have if you ceased to provide the services because you weren't being paid? Okay.
If I pick up the service redesign issue, so whether it's outcomes-based commissioning or a single control total or the regime we're under, I think we are working closer together on service redesign, particularly around emergency care. But increasingly we have to look at planned care flows, outpatients, etc. as well. But I think we are working together, both the trust teams, CCG teams and social care teams, to develop those propositions. And of course, alluding to your question, that's in the context of the South West London strategic and transformation plans as well, Croydon being its own sub-STP as well. Debtors, I'd have to pass over to John on.
I thought it was a specific question about in your paper. So what are we doing on debtors? Number one, we're working with NHS organisations who are our debtors in terms of commissioners and some of the other hospitals who are also obviously struggling for cash. Actually, we've managed to bring down our debtors by about 2 million over the last couple of months. So that's been helpful. So the first thing we've done is looked at internally within the NHS. So that's the major part of our debtors. We don't have many debtors that are non-NHS.
Just one point to make, and the question was asked, why are we in this situation? We're not going to be alone for long. So if 90% of acute trusts are in deficit, CCGs are not far behind at the moment. And so we've got, some of them are a bit ahead in terms of being in deficit. And so we're learning from all the plans that they're coming up with as well. And so part of our learning and our research is to look at what other people are thinking of in terms of changing services and recommissioning, decommissioning as well.
Okay, well, I think at this point, although we've got some, if you like, some housekeeping stuff that we can do at the end, which, since our members of the public have voluntarily already left, I'm going to move that we move to Part B now. Is everyone... Yeah. I'm just going to get the agreement first. Is that agreed?
Agreed.
Yeah. And so could we have the webcast turned off, please? And I'll just wait for confirmation that that's happened.